Hi everyone, and welcome to Emergency Nursing 2, Week 10 Metabolic Conditions. This week's lecture is completely online. You can find it on YouTube. Please remember to complete the online lab component case study that is posted on Blackboard. Remember to get working on your group presentations as well, and we will reconvene in next week's class. So for today's lesson, we will continue on talking about metabolic disorders. We had an introduction to the endocrine system last week when we talked about the AMP of things like the thyroid, parathyroid, adrenals, pancreas, hypothalamus, pituitary, and so on. Today, specifically in this audio recorded lecture, we will talk about pancreatitis, various thyroid disorders, and adrenal dysfunction. And this is covered in chapters 36 and 37 of Sheehy's Emergency Nursing Principles and Practice textbook, 6th edition. So first comes first is the patient assessment. Like we discussed last week, the endocrine system affects most, if not all, body systems. Complaints most commonly associated with endocrine disorders include fatigue and weakness, polyuria, polydipsia, weight changes, and mental status changes. The focused assessment should always target the specific presenting complaint that the patient has. When a critically ill patient presents to the emergency room, an endocrine etiology should be considered as part of the differential diagnoses. Care of the patient begins with assessment and stabilization of the ABCs, as well as a neurological assessment. The neurological assessment would include an evaluation of possible causes of altered consciousness, such as trauma, blood glucose abnormalities, stroke, or toxins. Identification of a stressor or precipitating event may be elicited through a patient history, family interview, lab findings, radiographic analysis, or other diagnostic procedures. We will focus over the next 2 weeks on a selected number of endocrine emergencies, but today we will talk about emergencies related to the pancreas, thyroid, and the adrenals. So remember back to last week when we reviewed the anatomy of the pancreas. So the pancreas is situated behind the stomach in the retroperitoneal space. The body of the pancreas extends horizontally across the abdominal wall, with the head of it in the curve of the abdomen and the tail touching the spleen. Exocrine and endocrine cells are found within the pancreas. We also have the islet of Langerhans. They produce alpha cells, beta cells, delta cells, and PP cells. When we talk about pancreatitis or acute pancreatitis, we are talking about an acute inflammatory process of the pancreas. Mortality ranges from 3% in patients with interstitial edematous pancreatitis to 17% in patients who developed pancreatic necrosis. Acute pancreatitis can be divided into 2 broad categories. The first is interstitial edematous acute pancreatitis, which is characterized by acute inflammation of the pancreatic parenchyma and peripancreatic tissues, but in this type there is no recognizable tissue necrosis. The second is necrotizing acute pancreatitis, which is characterized by inflammation associated with pancreatic parenchymal necrosis and or peripancreatic necrosis. The multisystem involvement in acute pancreatitis is a reflection of the pancreatic gland's capacity to produce a number of potent vasoactive peptides, hormones, and enzymes. The pathogenesis of hypocalcemia, long recognized as an indicator of the severity of acute pancreatitis, is very much multifactorial. Imbalances of parathyroid hormone, calcitonin, and the translocation of calcium ions in muscles and liver have been recently described, but remain somewhat conflicting. Hyperglycemia, hypoglycemia, and occasional ketoacidosis in acute pancreatitis have also been studied. Adult respiratory distress syndrome may be the result of active enzymes that digest pulmonary surfactant and microvascular thrombosis. Other pulmonary complications can include pleural effusions, pneumonia, and many more, So it's really important when we're assessing the patient who is diagnosed with acute pancreatitis that we assess the respiratory system, encourage the patient to get up and ambulate often, and if they can't, we should be repositioning them. The depression of cardiac function and shock are suspected to be secondary to vasoactive peptides. Shock, thrombosis, stroke, MI can also occur, so nursing interventions include monitoring vital signs and again, ambulating that patient or repositioning them, pressure stockings as needed. The onset of moderate visual disturbances or even blindness in a patient with acute pancreatitis as a result of retinal vessel thrombosis is really uncommon. Despite the extensive literature on the complexities of the pathogenesis of complications related to acute pancreatitis, there have really been very few advances in the prevention and management of specific complications. This is just a close-up view of the pancreas. You can see here we have the pancreatic duct, the inflamed and obstructed duct, edema and fat necrosis, and hemorrhages. Exocrine and endocrine functions of the pancreas. So exocrine and endocrine cells are found within the pancreas. Acini or acini are exocrine cells that release amylase, lipase, and other enzymes that aid in digestion. 3 types of endocrine cells within the islet of Langerhans produce hormones that regulate serum glucose levels. The alpha cells secrete glucagon, beta cells produce insulin, and delta cells secrete somatostatin, which inhibits glucagon and insulin release. You can see here in this PowerPoint presentation that I've included both exocrine and endocrine. So remember, exocrine produces and secretes digestive enzymes from acinar cells. Trypsin breaks down protein, amylase breaks down carbs, and lipase breaks down fats. Whereas the endocrine produces and secretes insulin from beta cells, which converts glucose into glycogen and lowers blood glucose levels. Glucagon from alpha cells, which converts glycogen to glucose and raises blood glucose levels. And somatostatin from delta cells, which inhibits the release of hormones such as insulin and gastrin. Although there are several causes of pancreatitis, 80% of all cases are caused by either alcohol or gallstones. Gallstones are the single most common cause of acute pancreatitis, and alcohol is the single most common cause of chronic pancreatitis. This is something important to remember. Some medications, most commonly corticosteroids such as prednisone, but also HIV medications, certain anticonvulsants, and chemo agents are also associated with increased events. This is just a visual of a mnemonic you can remember. I get smashed mnemonic. So it can be idiopathic, gallstones, ethanol or alcohol, trauma, steroids, mumps or malignancy, autoimmune, scorpion stings, which we don't really see here in Canada, hypercalcemia, ERCP, and drugs. This is a slide on the pathophysiology of pancreatitis. So there's an accumulation and activation of digestive enzymes within the pancreas. Inflammatory mediators are released, which can cause an inflammatory response, vasodilation, bronchoconstriction, tachycardia, and third spacing of fluids. And then there's increased blood glucose levels because there's an impaired insulin production because the pancreas is inflamed and not working as well as it could. I'd like you to take some time to pause this video and watch this YouTube video that gives you kind of a really good overview of what we've talked about so far, including the pathogenesis of the disease process. Moving on to the signs and symptoms. The signs and symptoms that I most often see in my own practice are extreme abdominal pain, nausea, and vomiting. Abdominal pain is really the cardinal symptom of acute pancreatitis. It's diffuse or mid-epigastric. It often radiates into the patient's back. It may start as a dull abdominal pain and then become very sharp and severe. It may worsen after eating fatty meals or drinking alcohol. In a patient with pancreatitis, we may also see hypertension, tachycardia, and fever. They may or may not have a pleural effusion. They have diffuse or rebound tenderness, abdominal guarding, decreased or absent bowel sounds, and in a patient with necrotizing pancreatitis, Gray-Turner's sign or Cullen's sign may be present. So you can see picture A is of Cullen's sign, which shows periumbilical ecchymosis, and in picture B shows Gray-Turner's sign, which is flank ecchymosis. Very important to note, if the patient does have these, it's very much emergency intervention. When assessing the patient with pancreatitis, you want to assess what signs and symptoms they are experiencing, if there is presence of any risk factors for pancreatitis, or if they've had it in the past, any allergies, complete a medication reconciliation of medications that they are on at home, and complete initially a GI assessment, remembering back to those complications, noting that you may also want to include a respiratory assessment and cardiac assessment. Some of the key diagnostic studies include a CBC, which will show an increased white blood cell count, possible thrombocytopenia, and hemoconcentration if the patient's dehydrated. You'd really like a complete metabolic profile. Sometimes they'll have high blood sugar levels, and again, it's because they're just not able to produce enough insulin. They might have elevated LFTs, decreased serum albumin, and possible electrolyte abnormalities if they're dehydrated or they've had a lot of vomiting. Oftentimes, in patients with pancreatitis, we will want an amylase level. It starts to rise within 2 hours of symptom onset and then will decrease within about 36 hours. It's not very specific, but I do find that in all the patients that I've had with pancreatitis, they've all had an elevated serum amylase, and it really does coincide with their symptoms. An elevated serum lipase, depending on the facility that you're at, this type of test can be done in-house, or at times, depending on the lab, the facility, how big the hospital is, it's a send-out test. It has more specificity. It rises within 4 to 8 hours and peaks around 24. It can stay elevated for about 2 weeks, and at least 3 times the normal range would indicate acute pancreatitis. Imaging studies can rule out other causes of abdominal pain, such as gallstones, which can somewhat mimic. A CT scan of the abdomen is considered the gold standard for imaging. It can be falsely negative in about 30% of cases, and an abdominal ultrasound. Identifying and treating the underlying cause is really important. So, is the patient getting pancreatitis because they have cholecystitis and they need gallstone removal or cholecystectomy? Do they have elevated serum triglycerides and we need to treat that? What's really going on with this patient? Let's look at that and treat that underlying cause. Like mentioned previously, alcohol abuse is a big factor in chronic pancreatitis, so we want to monitor for and treat alcohol withdrawal syndrome, get them some psychiatric counseling, and possible alcohol rehabilitation. And medications such as estrogens, thiazide diuretics, corticosteroids, and furosemide. This is just a picture overall that shows the diagnosis of acute pancreatitis, showing serum enzymes elevated, amylase and lipase, the assessment of the severity, whether it's mild acute pancreatitis or severe, and exactly what we're doing for that, and just kind of walks you through the treatment plan. Treatment goals overall include preserving normal pancreatic function, preventing complications, and nursing goals would be providing supportive care, pain management, limiting the systemic complications that I talked about a few slides back, and preventing necrosis. Supportive care would always first include our ABCs, IV hydration and fluid resuscitation with isotonic solutions, Pain management. So we really need to use valid and reliable pain intensity scales with these patients. Provide them IV opioids and really avoid Demerol with these patients. Demerol is not something we're seeing very often in hospitals. A lot of hospitals are removing it from formulary. Monitoring vital signs, intake and output, and continual lab work results. Early enteral nutrition, if required, would usually begin about 24 to 48 hours after illness onset. It overall enhances immune system function. It might help prevent complications because remember, this patient will be on NPO status with bowel rest. They may need parenteral nutrition after 5 to 7 days of early enteral nutrition if there's no improvement with their symptoms and disease process. And we really want to maintain a tight glycemic control. So because they're at risk for hyperglycemia, we may need to actually administer insulin to these patients. So moving on to the thyroid, you can review last week's slides for more thyroid anatomy and physiology. But just remembering back that the thyroid gland consists of 2 lobes connected by an isthmus. This butterfly-shaped gland in the anterior neck below the cricoid cartilage partially surrounds the trachea. Thyroid hormone release is regulated through a complex feedback system between the hypothalamus and anterior pituitary. This main metabolic regulator contains follicular cells that secrete thyroxine T4 and T3 in response to stimulation by the pituitary. Calcitonin, originating in parafollicular cells in the thyroid, affects calcium metabolism. The parathyroid glands are 4 or more small glands located on the posterior surface of the thyroid gland. The sole function of these glands is to maintain the body's calcium level within a very narrow range so that the nervous and muscular systems can function normally. When serum calcium levels drop, calcium sensing receptors in the parathyroid gland are activated to release parathyroid hormone. Parathyroid hormone, also known as PTH, increases blood calcium levels by stimulating osteoclasts to break down bone and release calcium. It also increases gastrointestinal absorption of calcium by activating vitamin D and promotes calcium reabsorption by the kidneys. So our thyroid hormones, again, which are important to remember, are our T3 and our T4. And then we also have our thyrocalcitonin or calcitonin. This next slide is the hypothalamus-pituitary-thyroid feedback loop, regulated synthesis and secretion of thyroid hormones. This is what it does. It helps to really regulate and synthesize and secrete thyroid hormones. So thyroid emergencies are quite rare, but can be very life-threatening. The thyroid gland regulates the body's metabolic rate through the hypothalamic-pituitary-thyroid counter-regulatory system. The thyroid gland activity depends on the hypothalamus secreting TRH, which is responsible for the release of TSH by the anterior pituitary, which in turn causes the release of T4. Circulating T4 is converted to T3 in the peripheral system. The amount of TSH depends on the amount of TRH, which can be influenced by physical stressors such as surgery, infection, extremely cold temperatures. Circulating levels of T3 and T4 also affect the amount of TRH released through negative feedback. If any part of this system malfunctions, the resulting hyperactivity or hypoactivity of the thyroid gland can lead to multisystem symptoms. Hyperthyroidism, or overactive thyroid, is a condition in which your thyroid gland produces too much of the hormone thyroxine. Hyperthyroidism can accelerate your body's metabolism significantly, causing sudden weight loss, rapid or irregular heartbeat, sweating, nervousness, or irritability. Several treatment options are available if somebody has hyperthyroidism. Doctors will use anti-thyroid medications, possibly radioactive iodine, to slow the production of the thyroid hormones. Sometimes treatment of hyperthyroidism involves surgery to remove all or part of the thyroid gland. And although hyperthyroidism can be serious if it's ignored, most people will really respond well once hyperthyroidism is diagnosed and treated. Complications include heart problems such as rapid heart rate and atrial fibrillation, brittle bones, eye problems, and thyroid crisis, which we will talk about later in this presentation. Graves' disease, an autoimmune disorder in which thyroid-stimulating immunoglobulins increase thyroid activity, is responsible for about 60 to 80% of all cases of hyperthyroidism. The next slide is just a visual of some of the symptoms that the patient would experience. Hypothyroidism. So the thyroid gland is not making enough thyroid hormone. Major causes include autoimmune disease, surgery on the gland, radiation treatment because of Graves' disease or cancer, congenital, thyroiditis, and medications that prevent the thyroid gland from functioning normally. Too much or too little iodine because the gland must have iodine in order to make the thyroid hormone. So sometimes treatment for hyperthyroidism can actually cause hypo. The diagnosis is really based on the symptoms that the patient is experiencing, a medical and family history, physical exam, and blood tests. TSH test is the most important and sensitive test for hypothyroidism. It measures how much of the T4 hormone the gland is being asked to make. An abnormally high TSH means the patient has hypothyroidism. The gland is making too much T4 because there isn't enough of it in the blood. Hypothyroidism cannot be cured, but in almost every patient it can be completely controlled. It is treated by replacing the amount of hormone that your own thyroid can no longer make, so that your T4 and TSH levels can go back to normal. So even if your thyroid gland cannot work properly, T4 replacement can restore your body's thyroid hormone levels and your body's function. Synthetic thyroxine pills contain hormones exactly like T4 that the thyroid gland itself makes. All hypothyroid patients, except those with severe myxedemia, which is a life-threatening form of hypothyroidism, can be treated as outpatients, not having to be admitted to the hospital. This next slide just kind of gives you a visual on the differences between underactive and overactive thyroid and the symptoms that the patient may experience. So moving on to thyroid storm. Thyroid storm is an acute, life-threatening complication of poorly managed hyperthyroidism or thyrotoxicosis. So symptomatic hyperthyroidism. There's rapid elevation in thyroid hormone levels, and this results in a decompensated state of severe hypermetabolism, which is characterized by hyperthermia, agitation, tachydysrhythmias, and tremors. Neurological symptoms may include delirium, syncope, or coma. If it's left untreated, mortality rates can be quite high, around 90%. Exhaustion, cardiac failure, and death can occur really in just a few hours. Elevated hormone levels can occur in response to hospitalization, surgery, infection, emotional stressors, trauma, childbirth, sudden discontinuation of antithyroid medications, or over-manipulation of the thyroid. The patient may be restless with a shortened attention span and appear to be having an anxiety attack. Tremors and manic behaviors are also common. In late stages, the patient may have altered mental status progressing to coma. Hyperthermia may be extreme with temperatures reaching 40.5 to 41 degrees Celsius. Older adult patients may present with rapid new onset AFib. Tachycardia with rates as high as 200 to 300 beats per minute will increase the patient's risk for cardiac failure and arrest. Pulmonary crackles secondary to cardiac failure may be heard. The skin often progresses from warm and diaphoretic to hot and dry as dehydration worsens. Nausea, vomiting, diarrhea are all caused by increased gastric motility. Liver tenderness, jaundice, and thinning of the hair may occur. Goiter, an enlarged thyroid gland, develops as the condition progresses. The eyes become protuberant. Periorbital edema can develop. And the patient has a staring type gaze with heavy eyelids. This all may result from autoimmune disorders, infection, trauma, manipulation of the thyroid gland, stress, all these things that I just briefly talked about. So with the physiological results of hyperthyroidism, again, increased metabolic demands, increased oxygen demand, increased SNS response, increased CNS, CVS, and smooth muscle activity, heat production, and the increase in the sodium-potassium pump activity. So for the management of this patient, immediate goals for management of a thyroid storm include inhibiting thyroid hormone synthesis and release, blocking peripheral thyroid hormone effects, and supportive care such as the management of ABCs. Controlling hyperthermia is really important. Beta blockers might be given to inhibit adrenergic effects, but should really be used with caution in the older adult and in patients with pre-existing heart disease, COPD, or asthma. Certain medications, such as PTU, may be used to block further synthesis of thyroid hormone. Both are given orally or through a gastric tube. Iodides can be given to block the conversion of T4 to T3 and inhibit hormone release. After the patient stabilizes, close evaluation and assessment are necessary to identify the aggravating agent or illness. Lab analysis would include blood cultures, toxicology screens, thyroid function, electrolyte levels, and CBC. X-rays may be ordered or other radiographs to rule out infectious sources. Head and neck CT scans can be ordered to identify existing neoplasms or structural abnormalities, and antibiotic therapy may be started if infection is thought to be a causative agent. Moving on to myxedema coma. So this is an extreme complication of hypothyroidism, in which patients exhibit multiple organ dysfunction and progressive mental deterioration. Hypothyroidism is 4 times more common in women than in men, with 80% of the cases of myxedema coma occurring in females. Myxedema coma usually occurs in patients 60 years and older, with more than 90% of cases occurring during the winter months. Mortality rates may be in and around the 30 to 60% range. So untreated hypothyroidism progresses over months to years before culminating in myxedema coma. All patients who develop this have hypothyroidism. Dysfunction may be related to autoimmune thyroiditis, ablation therapy from treatment of hyperthyroidism, iodine deficiency, tumor activity, or drug therapy. So in supporting this patient, we really want to support the ABCs. This is an essential part of treatment plan. The tongue may be thick and can obstruct the airway in a semi-conscious or unconscious patient. Weak respiratory effort with decreased respiratory drive leads to alveolar hypoventilation and can predispose the patient to pulmonary infection. Alveolar hypoventilation also leads to hypercarbia, which can further confound an altered mental status. Obesity-related sleep apnea can further compromise the respiratory system, and respiratory failure is the usual cause of death. Cardiac changes include decreased heart rate, decreased stroke volume, and decreased cardiac output. In myxedema coma, renal blood flow, glomerular filtration rates, and sodium reabsorption rates decrease. Occasionally, hypoglycemia as a result of increased insulin sensitivity and decreased oral intake can occur. So moving on to our adrenals. So remember back again to last week. The adrenal glands are located in the retroperitoneal area above the upper pole of each kidney. They consist of an outer cortical layer and an inner medullary layer. The adrenal cortex produces mineral corticoids like aldosterone, glucocorticoids like cortisol, and androgens. Aldosterone is critical for maintaining internal fluid balance, whereas glucocorticoids are major players in the body's ability to resist stress. The adrenal medulla releases the catecholamines epinephrine and norepinephrine in response to sympathetic stimulation. This again is a slide just taken from last week's PowerPoint. And the adrenal physiology, which I just reviewed, and remembering back to last week's lecture in class. And again, adrenal medulla, adrenal blood supply, all a review of last week. Acute adrenal insufficiency, also known as adrenal crisis or Addisonian crisis, is a rare occurrence with life-threatening potential. It's characterized by a depletion of adrenal glucocorticoids and mineral corticoids. The crisis can occur in a person with Addison's disease or might be caused by sudden withdrawal of long-term steroid therapy, removal or injury of the adrenal glands, or destruction of the pituitary gland. Normally, stress increases cortisol output from the adrenal system. Therefore, an inability to meet these increased demands begins the sequence of events that lead to crisis. When the adrenal system fails, the resulting decrease in cortisol and aldosterone levels leads to sodium and water loss from the kidneys and GI tract. Water loss results in hypotension and hypovolemia, which can progress to cardiovascular collapse, coma, and death. As sodium decreases, serum potassium increases, leading to hyperkalemia and potentially fatal dysrhythmias. Glucogenesis, the normal hepatic response to stress, fails without sufficient levels of cortisol. Therefore, hypoglycemia can also occur in adrenal crisis. Decreased cortisol levels also alter activities of the adrenal medulla, which normally respond to stress through the release of catecholamines, which increase heart rate and serum glucose. Without a catecholamine response, the severity of hypoglycemia and hypotension is really magnified. Classifications of Addison's disease can be primary or secondary in nature and are listed here. The clinical presentation varies a little bit. The patient may complain of headache, fatigue, weakness, weight loss, palpitations, gastrointestinal symptoms such as nausea, anorexia, abdominal pain, and chronic diarrhea. Signs and symptoms can also include sudden pain in the abdomen, lower back or legs, severe vomiting and diarrhea. If the patient is suffering from an infection, a high fever might be present, dehydration, low blood pressure, and eventually will lead to loss of consciousness. So shock is something that can happen in the clinical presentation due to cortisol deficiency. Also, decreased water retention in the kidneys, hypoglycemia, again because of that decreased cortisol, hyperkalemia due to decreased renal excretion of potassium. Maintenance of our ABCs, replacement of glucocorticoids, and correction of fluid and electrolyte disturbances are cornerstones of care for the patient with an adrenal crisis. Oxygen should be administered as needed to keep the saturations up. Hydrocortisone is the primary glucocorticoid given to stimulate glucogenesis. inhibit inflammatory responses, and really allow the body to increase its response to stress overall. Rapid IV replacement assists in correcting volume deficit, which can be significant in adrenal crisis. A bedside glucose levels should be obtained, and hypoglycemia should be corrected if it's present. High potassium associated with adrenal crisis is usually mild and resolves with IV fluids and replacement of glucocorticoids. However, if the patient has signs and symptoms of hyperkalemia or any type of ECG changes, the patient should be treated. Remember back, we talked about the treatment of high potassium last week, which includes the use of calcium, sodium bicarbonate, insulin, and 50% dextrose. It's important to remember how we treat high potassium. Continuous cardiac monitoring in these patients is also really essential. So that's about it for our lecture today. So what's happening over the next few weeks? Next week, we are going to move on to diabetes, DKA, HHNS, and diabetes insipidus. We will review chapters 36 and 37 again next week, so that's about 3 weeks of the same chapters. In lab next week, we will talk about the assessment and management of hyper and hypoglycemia. The following week, week 12, we'll talk a little bit more about that next week, but really it's just putting all those pieces together, getting ready for our upcoming group presentations, which will occur in week 13. So thank you so much for listening today, and I will see you soon.